Hello, I'm Dr. Vicky Cleak, a Consultant General Adult Psychiatrist. Today I want to talk to you about something many people experience and which can lead to significant long-term mental health problems, but which is completely avoidable. What it means when an antidepressant seems to make your mood worse rather than better. And just to be clear up front, this video is not about typical side effects that antidepressants can cause that trouble you. It's about what can happen when someone is prescribed an antidepressant for depression that is actually part of an undiagnosed bipolar disorder, a manic depression. Most people with depression improve within 2 to 4 weeks of starting an antidepressant. Usually they're started on an SSRI medication like fluoxetine or sertraline, or an SNRI medication such as venlafaxine. But sometimes the opposite happens. The mood doesn't lift or it worsens. A person may become more agitated, irritable, restless, unable to sleep, or even start showing symptoms of what we call hypomania or mania. This is all out of normal character. When that happens, we must ask ourselves an important question. Was the original diagnosis correct? Around 1 in 4 people will experience depression at some point in their lives, but for a significant minority, that depression is actually part of what we call a bipolar affective disorder, either a bipolar 1 or a bipolar 2 illness, which often goes undiagnosed for years. Research has shown that the average delay to diagnosis is about 8 to 10 years from when the first mood episode occurred for bipolar. And why is that? Well, because people tend to seek help when they're low rather than when they're high. A hypomanic period can feel to the individual that they're being very productive, sociable, energetic, so they're rarely reported unless things start to go wrong. In bipolar depression, antidepressant monotherapy, an antidepressant being used by itself, can be ineffective or destabilising and increase the risk of either a mixed state, switching into a hypomanic or manic state, or developing faster, more frequent mood episodes, which we call rapid cycling. This isn't just a bad reaction to the medication, it's a sign that the treatment doesn't match the underlying condition. So how does this show up clinically or for the individual themselves? Well, there are a few common patterns which give us an idea that this might be the case. In a mixed affective state, low mood persists, but the person becomes more agitated, restless, anxious, with racing thoughts and poor sleep. It's one of the most uncomfortable mood states that a patient can experience and is linked to a much higher risk of suicide or suicide attempts. And antidepressants can trigger or worsen this in a bipolar disorder. In a hypomanic or manic switch, there is a noticeable increase in a person's energy, a reduced need for sleep, more impulsive behaviour that's very out of character, overspending, irritability or euphoria. A person may describe speeding thoughts and may speak faster. Large studies show that this risk is significantly higher in people with a bipolar disorder who take antidepressant medications alone. And in rapid cycling, mood episodes start occurring more frequently, 4 or more times a year, of switching between low mood and highs, sometimes triggered or accelerated by antidepressant use. So the key takeaway of this is that if an antidepressant is making things worse in terms of your mood, then bipolarity must be considered. This is also the case if you are having recurrent low mood episodes despite being on antidepressant medication. So why might the diagnosis of bipolar be missed in the first place? Well, misdiagnosis is very common and happens for several reasons. Firstly, as I've touched upon already, people often present only when they're depressed, not when they're high for help. Being hypomanic feels good, so individuals may not view it as part of their illness. Partners or family may notice overspending, the impulsivity, the irritability, or alcohol and drug use, but not realise it's related to their mood, and may understandably focus on the depressive episode and thus start an antidepressant without really exploring whether there have been any other past episodes of low mood or elevated mood, particularly after starting antidepressants or immediately preceding a low episode. Some red flags suggesting a bipolar rather than a unipolar depression include depressive episodes with increased sleep, which we call hypersomnia rather than insomnia, or reduced sleep, and increased appetite. A family history of bipolar affective disorder or up and down moods, Periods of elevated mood, irritability, overspending and risk-taking which are out of character of the individual in between times, and mixed features such as agitation, racing thoughts and restlessness. An early onset of depression in a person's life, having it at a young age, having frequent episodes or rapid cycling, and poor or paradoxical response to antidepressants. So what does treatment look like if bipolar affective disorder is suspected? Well, if bipolar affective disorder is likely, the treatment approach changes significantly, and I cannot emphasise this enough. Most GPs will really need to seek support from a psychiatrist to do this, as it requires secondary care expertise and it's difficult to manage in primary care. Instead of antidepressants, first-line treatment needs to be a mood stabiliser of some form, either a traditional mood stabiliser such as lithium or sodium valproate, or an antipsychotic with mood stabilising properties. Now, lithium use is the gold standard treatment. It helps both highs and lows and is shown to reduce the risk of suicide attempts and has been used for a really long time. So we've got good research on how effective it is and what the risks of using it consist of. It does need close monitoring by a specialist, however. Lamotrigine is an alternative mood stabiliser and is especially useful for those with depression-dominant bipolar affective disorder. And then there's quetiapine or lurasidone, which are antipsychotics, of which there is good evidence that they help in bipolar depression. But the choice of which to use is complicated and depends upon a patient's mood history, any family response to medications, and their own views on side effects as well as the risks involved. However, antidepressant monotherapy should be avoided, and if used at all, it must be combined with a mood stabiliser and only in carefully selective cases, short-term and with supervision. It's important to tailor the treatment of bipolar to the current episode when a person presents. So if you're depressed, you choose a medication based on the patterns of highs and lows and the presence of any mixed features. If the person presents with hypomanic or manic episode, then the elevated mood is the main focus of treatment. But if the person is stable, then you want to focus on prophylaxis and the prevention of future mood episodes. Now, we know that medication alone isn't enough. Psychoeducation to understand the individual's illness signature with regular routines, good sleep hygiene and reduced alcohol and drug use is really important, as well as early warning sign monitoring and having a plan in place for if the mood deteriorates. Ongoing monitoring with mood charts and including sleep diaries can all help to detect early mood shifts. Bipolar UK has some essential resources to help with this. So the practical takeaways of this are that if the mood worsens in someone presenting with depression on an antidepressant, then always consider that they might have a bipolar illness. Ask about past periods of high mood, reduced sleep, increased confidence, irritability, spending, or risky behaviour that is out of character. Create a simple life chart of past mood events and triggers to understand the frequency of episodes and their particular impairment. And prioritise mood stabilisers or antipsychotics with mood stabilising properties over antidepressant monotherapy. If an antidepressant is considered, only use it alongside a mood stabiliser and monitor it closely. So thank you for watching. If you found this helpful, please like, subscribe and share with others that might find it useful too. As always, this video is for education purposes only and cannot ever replace an individual clinical assessment or specialist advice. See you next time. Take care. Goodbye.